My name is Ricky Crumpton, and it is October 19th, 2024. Hi class, we are together again to complete another case connection assignment for Unit 4. I will read the case first, and then we will have discussion questions afterwards. If there are not any questions, let's begin. The first case reads, a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. A full blood work was ordered for this female, and the data is presented below. The initial blood ammonia level was elevated at 314, normal range 17 to 80, and rapidly rose to 600. Further analysis shows urine uric acid levels were marked elevated at 473 creatinine. The plasma citrulline level was normal at 10. Now let us break down the first case with some review questions. Discuss the normal mechanisms of ammonia transfer in the body that should be occurring, including glutamate dehydrogenase, glutaminase, and glutamine synthetase. Be sure to discuss the role of transamination. An important route for ammonia detoxification, particularly in the brain and muscle, is glutamine synthetase, an enzyme that catalyzes the conversion of glutamate and ammonia into glutamine. The liver or kidneys are the next organs where glutamine can be moved to undergo additional metabolism. Glutaminase. The enzyme breaks down glutamine into glutamate and free ammonia in the liver, kidneys, and intestines. To be detoxified, the released ammonia enters the urea cycle. Ammonia is eliminated from the urine by the kidneys as a part of the acid-base balance process. The reversible reaction that transforms glutamate into alpha-ketoglutarate and releases ammonia is catalyzed by the enzyme glutamate dehydrogenase. The liver can use the released ammonia to detoxify itself by entering the urea cycle. By moving an amino group from an amino acid to an alpha-keto acid, typically alpha-ketoglutarate, transamination creates glutamate. For nitrogen to be utilized for urea synthesis or to be converted into glutamine for transportation in the liver, transamination is essential for the movement of nitrogen from different tissues to the liver. How is nitrogen transport connected to gluconeogenesis in the fasted state? Nitrogen is obtained primarily from breaking muscle protein amino acids during a fast. Nitrogen is incorporated into glutamate during the transamination of these amino acids in peripheral tissues such as muscle. With the enzyme glutamate dehydrogenase, glutamate can be transformed into glutamine or released as ammonia. The nitrogen is utilized by the liver to form urea through the urea cycle, after glutamine and ammonia are transferred there. Moreover, the transamination process produces alanine, which is then transferred to the liver, where it plays a role in the urea cycle, eliminating nitrogen and gluconeogenesis, which releases glucose. In this individual where uric acid levels are elevated, what urea cycle enzyme is most likely deficient and what urea cycle enzyme is least likely to be impaired? Be sure to justify your answers. Significantly higher uric acid is present in this patient. This results from an ornithine transcarbamylase deficiency. The normal process by which this enzyme produces citrulline involves transferring the carbamoyl portion of the carbamoyl phosphate to ornithine. Carbamoyl phosphate exits the mitochondria and serves as a substrate for carbamoyl phosphate synthetase 2 in the cytosol when this enzyme is inadequate. A typical intermediate in the synthesis of pyrimidines, uric acid would rise as a result. The most likely deficient enzyme is ornithine transcarbamylase. The least likely enzyme to be affected is carbamoyl phosphate synthetase 1. Which amino acid, if any, becomes essential as a result of this deficiency? Plasma citrulline levels are frequently undetectable in the acute phase in patients with ornithine transcarbamylase (OTC) deficiency. An arginine deficiency would then follow from this. Consequently, it turns into an essential amino acid. Awesome job discussing the first case, class. Now, let's move forward to case number 2. Scenario 1. A full-term girl was born by normal vaginal delivery and was released from the hospital at 3 days of age. At 9 days of age, a screening test for branched-chain amino acids came back positive, and the child was readmitted to the hospital for further evaluation. There was no history of any genetic disease in either family, and both older siblings were well. Scenario 2. A 69-year-old woman presented with a 30-year history of lower back and large joint pain of the hips and shoulders. On examination, blue-gray pigmented macules were present over the cartilaginous portions of the ears and on the sclera. Past medical history included aortic stenosis. Scenario 3. A 4-year-old infant is being followed in your clinic. Her birth weight was 5.9 pounds, and the pregnancy and birth vaginal delivery were normal. Results from newborn screening demonstrated a phenylalanine level of 6.6, normal range 1 to 2. For each scenario, we will determine 1. Most likely enzyme deficiency in which amino acids is no longer metabolized. 2. If any amino acids become essential as a result of the deficiency. 3. Potential vitamin supplements that may be useful for the condition and what steps in the metabolism they could potentially help with. For scenario 1, the child has maple syrup urine disease due to a deficiency in branched-chain alpha-keto acid dehydrogenase. This means the child has trouble metabolizing the amino acids valine, leucine, and isoleucine, which are essential for various bodily functions such as protein and fatty acid synthesis. Although the illness prevents the breakdown of these amino acids, they are still necessary and should be included in the child's diet. Thiamine is a cofactor for the BCKD enzyme complex, and thiamine supplements can help some patients with a milder form of MSUD function better. Thiamine pyrophosphate is specifically needed as a cofactor for the BCKD complex, and thiamine helps it work properly. For scenario 2, the woman's homogenizate 1,2-deoxygenase enzyme deficiency results in alkalinuria. Homogenic acid builds up in the person's connective tissue when this enzyme is lacking, resulting in an illness known as acrokernosis. In alkalinuria, no extra amino acids are required, so tyrosine and phenylalanine are not metabolized. Children with this enzyme disorder don't exhibit any symptoms, so treatment may be put off, which could lead to issues with the spine, joints, and other organs. Gray or blue discolorations on the sclera and cartilage portion of the ear are one of the clinical symptoms. Taking vitamin C supplements is one way to treat this enzyme disorder. By inhibiting homogenization and polymerization, vitamin C may work to stop acrokernosis and additional joint damage. For scenario 3, phenylalanine hydrogenase is an enzyme that is lacking in the infant. The genetic condition known as phenylketonuria is caused by this deficiency. The metabolism of the amino acid phenylalanine is carried out by phenylalanine hydroxylase. If left untreated individuals may develop characteristics like hypopigmentation, light patches on the skin, behavior issues, and microcephaly. Dietary restrictions on foods high in phenylalanine are used to manage the disorder. When phenylalanine cannot be converted to tyrosine becomes an essential amino acid in people with PKU. This disorder is not treated with vitamins or supplements. I do appreciate each of you engaging in our Unit 4 case connections, and I hope your learning was enhanced with new information. I have provided the sources below to support our discussions today. If you have additional questions, please contact me. Thank you and have a great day.